APGO Educational Topic Number 18, Preeclampsia. Preeclampsia is a hypertensive disorder of pregnancy diagnosed after 20 weeks gestation. Eclampsia is a new onset seizures in a woman with preeclampsia. Hypertensive disorders of pregnancy complicate up to 10% of pregnancies worldwide, and the incidence of preeclampsia in the United States has increased by 25% in the last 2 decades. Preeclampsia is a leading cause of maternal and perinatal morbidity and mortality, with an estimated 50,000 to 60,000 related deaths per year worldwide. The objectives of this video are to define the types of hypertension in pregnancy, describe the pathophysiology of preeclampsia, list the risk factors for preeclampsia, and describe the diagnosis, management, and complications of preeclampsia. The 4 types of hypertension in pregnancy are preeclampsia, chronic hypertension with superimposed preeclampsia, and gestational hypertension. Preeclampsia is defined as new onset hypertension after 20 weeks gestation with proteinuria or end organ dysfunction. Chronic hypertension predates the pregnancy or is diagnosed prior to 20 weeks gestation. Superimposed preeclampsia involves signs and symptoms of the disorder along with chronic hypertension. Gestational hypertension is an elevated blood pressure diagnosed after 20 weeks without the systemic findings of preeclampsia. During normal pregnancy, fetally derived cytotrophoblasts invade the maternal uterine spiral arteries and replace their endothelium, converting the high-resistance, small-diameter vessels into high-capacitance, low-resistance vessels to ensure adequate delivery of maternal blood to the placenta. As you can see in this healthy placenta, the spiral artery is lined with cytotrophoblasts, making it nice and wide to ensure a lot of blood flow. In a woman destined to develop preeclampsia later in her pregnancy, this process does not occur correctly, and the arteries remain narrow, decreasing blood flow to the placenta and causing hypoxemia. Studies have shown abnormalities in vasculogenic and angiogenic signaling pathways, but the exact mechanism for this abnormal trophoblast invasion remains unclear. The biggest risk factor for preeclampsia is history of preeclampsia in a previous pregnancy, which increases the risk 7-fold. Preeclampsia in a first-degree relative, primiparity, and multiple gestation are also important risk factors to consider. The mother's past medical history should also be reviewed for risk factors, including pre-existing hypertension, renal disease, hypercoagulability, diabetes, obesity, lupus, and age greater than 40 years. Nonetheless, it is important to note that most cases of preeclampsia occur in healthy nulliparous women with no other obvious risks. The diagnosis of preeclampsia can only be made with a combination of elevated blood pressure and proteinuria or systemic findings. The blood pressure must be greater than 140/90 on 2 occasions at least 4 hours apart after 20 weeks gestation. Proteinuria is defined as greater than 300 milligrams per 24-hour urine collection, a protein creatinine ratio greater than 0.3, or a dipstick reading of 1+. In the absence of proteinuria, severe features including a platelet count less than 100,000, serum creatinine greater than 1.1, elevated liver transaminases to twice normal concentration, pulmonary edema, or new onset cerebral or visual symptoms can also make the diagnosis. The management of patients with preeclampsia involves weighing the risks of maturity of the fetus with the risks of maternal morbidity of worsening disease progression. Preeclampsia is managed by close surveillance until 37 weeks estimated gestational age. This involves monitoring the mother carefully with frequent blood pressure monitoring, serum, and urine evaluation to watch for disease progression. Antihypertensives, such as hydralazine, labetalol, or nifedipine, should only be started if the blood pressure exceeds 160 systolic or 110 diastolic. Ultrasound for fetal growth should be offered, and if evidence of restriction is found, fetal placental assessment, including umbilical artery Doppler velocimetry, is recommended. The fetus should be monitored with twice-weekly non-stress tests as well. Betamethasone should be administered for fetal lung maturity prior to 34 weeks estimated gestational age, and delivery should be initiated at 37 weeks. Once the diagnosis of preeclampsia with severe features is made, delivery should be initiated after 34 weeks. If there is concern for rapid disease progression, then delivery will need to be initiated even prior to 34 weeks. Magnesium sulfate is administered for seizure prophylaxis. The mode of delivery should be decided by fetal presentation, cervical status, fetal gestational age, and maternal fetal condition. Eclamptic seizures are scary occurrences, and it is critically important to stabilize the mom first, for this will stabilize the fetus. Women with eclamptic seizures should be treated with parenteral magnesium. Mode of delivery is again decided by maternal fetal condition, and vaginal delivery can often be attempted with labor induction, even in the case of eclamptic seizures. Preeclampsia is a progressive disease. The hypertension may worsen, or signs of end organ dysfunction may manifest over time, including eclampsia, HELLP syndrome, placental abruption, stroke, liver or kidney injury, and ARDS. Eclamptic seizures may occur before, during, or after labor and result in high perinatal and maternal morbidity and mortality. HELLP stands for hemolysis, elevated liver enzymes, and low platelets. Is usually diagnosed in the third trimester of a woman with preeclampsia or gestational hypertension with symptoms of epigastric pain, malaise, nausea, and/or headaches, and can progress to DIC. All of these issues are solved by delivery of the baby and placenta. Fetal complications include fetal growth restriction and the issues associated with increased risk of preterm delivery and placental abruption. This concludes the APGO video on preeclampsia. We have reviewed the definition, clinical features, and management techniques of this common condition in pregnant women.